I'm Professor Steve Goldstein, and I am speaking to you today from New York City in the United States. Also the current president of the International Menopause Society. And so it was with great pleasure that I'm getting to introduce and moderate this session entitled Dealing with the Big Issue, Weight Gain at Midlife. We are extremely fortunate to have two very distinguished speakers and panelists, and I will introduce them both now and then give them the floor, the podium, the virtual podium. Professor Jim Simon is a gynecologist, endocrinologist, and sexuality counselor. He's actually the only physician to ever serve as president of the North American Menopause Society, NAMS, and ISWICH, the International Society for the Study of Women's Sexual Health. He's conducted over 400 clinical research trials, more than 600 publications, including the book, Restore Yourself, A Woman's Guide to Reviving Her Sexual Desire and Passion for Life. And I can say on a personal note, Dr. Simon has had a tremendous interest in weight gain at midlife, and will be speaking to us today on that topic. His actual title is Body Weight, What Happens at Menopause, an Evolutionary Perspective. Following Dr. Simon, I'm really pleased to have Professor Angela Fitch. She is co-director of the Massachusetts General Hospital Weight Center, where she's an assistant professor of medicine at the Harvard Medical School. She's board certified in obesity medicine, internal medicine, and pediatrics. And she is the president-elect of the Obesity Medicine Association here in the United States. So we have an extremely interesting group of speakers and panelists. And this webinar was supported by an unrestricted educational grant from Besson's Healthcare. Besson's Healthcare had no role in the selection of topics, selection of speakers, and have not vetted or reviewed the content of the speakers' presentations. And now I'd like to give the virtual podium to Professor Simon.
So as Dr. Goldstein said, it's my great pleasure to talk to you this morning about body weight and the impact of menopause, but to introduce you all to an evolutionary perspective on menopause and how it might apply to weight gain at midlife. These are my disclosures. As Dr. Goldstein mentioned, I do a tremendous amount of clinical research. I would also say that none of them, at the present time at least, none of them impact my comments today as they relate to weight gain and obesity issues. So the learning objectives of my lecture are to appreciate the psychosocial biases on overweight and obese individuals in contemporary society. And I would also say that all three speakers today are from the US, and by the very nature of our comments, this is a US perspective, as there are still many women and men around the world, not to mention children, who have food insecurity, and obesity is the least of their problems. I would also like to comment on fat shaming and or fat biases as they impact our care, both from the patient and the practitioner perspective. We should know the definitions of overweight and obesity, their etiologies, and how excess weight impacts one's health, particularly in women at menopause and from the point of view of the OBGYN and primary care setting. And I'd like to introduce a preliminary understanding of some physiological changes that occur at menopause before introducing or passing the baton to Dr. Fitch, who will talk about treatment of the issues of overweight and obesity. So what is weight bias? These are negative attitudes toward individuals with overweight and obesity, and these lead to very significant stereotypes listed for you here, including discrimination, how we address them from the point of view of our language, and shaming in all aspects of our interactions. This older study is as relevant today as when it was first published. It shows the rates of discrimination among adults 25 to 74, large sample size, and both men and women as it relates to bias from weight and overweight and obesity. It is third or fourth on the hit parade, if you will, to gender, race, and age discrimination, but more important than even sexual discrimination or other aspects of religious discrimination, et cetera, making it a very important endpoint for us to contend with in our psychosocial and biological approaches to managing these patients. For example, visual portrayals of people with obesity in all aspects of the media demonstrate our presentation of them without heads, shown from the side, displaying their weight and lower body, bare midriffs, etc. And I'll show you just one example of these. These are pictures taken from the US media, and they are emblematic of how individuals with overweight and obesity are portrayed publicly. Physicians and other healthcare professionals are not immune from this problem as well. We view patients with obesity as, and these are demonstrated in the literature and have not really changed, we view patients with obesity as having less discipline, being less compliant to treatments, and in fact, being more annoying. Patients, BMI as it increases, we say or report that we have less patience with them, less desire to help them, that sometimes they're a waste of our time, and we generally have and display less respect for these patients. Our office staffs are no different than we are. They view patients who are overweight and obese as being lazy, having less self-control, less willpower, and being non-compliant. And in one study, 31% of our office staffs said that they would prefer not to care for patients with obesity, and 24% agreed that patients with obesity actually repulsed them. So without going into this any further, I would just ask everyone to be a little introspective, question your own motivations and approaches, and to be careful in hiring and including your staffs when you address the issues of overweight and obesity in your patients, because they have some of the same problems that all of us and society generally have. When you talk about weight with patients, we'd like you to use neutral terms like weight and unhealthy weight, and try to avoid terms like fat, obesity, or being morbidly obese. I personally use the following language as a routine in an effort to get patients to open up about their weight issues. For example, I would say, could we talk about your weight today? Or when are you wanting to address your unhealthy weight? Something like that, which is less judgmental and which puts the patient's goals and interests and desire first. There's no question that obesity and even overweight has major, I cannot emphasize it enough, major impacts on health. Some of the endpoints are listed for you here. They have all been documented over and over and over again. And as it relates to women specifically, I'll point to these gynecological abnormalities ranging from abnormal menstrual function and infertility and polycystic ovary syndrome to many cancers that are women's cancers particularly, but also human cancers focused on breast and uterus specifically being dramatically increased with weight. It is reproductive, and you will see by my theoretical evolutionary perspective, it is reproductive benefits of having extra calories, at least in a historical and evolutionary perspective, that challenge women even more than men. So if you look across the life cycle from age 20 to age 80, including childbearing years and postmenopausal years, at the percentage of women with overweight or obesity, you can see that it increases, and this is a US perspective, it increases from the 20s to the 40s, again from the 40s to the 60s, and then becomes most prevalent in women in the menopausal and aging years. This is emphasized by the impact of childbearing, which I'll show you in just a minute, and it affects both our efficacy in childbearing, documented most recently as an impact of weight and fat generally on the efficacy of even in vitro fertilization, controlling for as many other variables as possible, but also on the impact it has on pregnancy, preeclampsia, for example, as well as postpartum. I love this slide. It shows very clearly that if you look at the BMIs of individuals as it relates to the number of pregnancies with excessive weight gain, it demonstrates very clearly a complete, slow, and progressive increase in BMI as it relates to the number of pregnancies. So weight gain at pregnancy, because many women never lose their, quote, baby fat, unquote, they continue to increase their BMI as they age and as a result of increasing numbers of pregnancies. So what happens at menopause? Well, a lot of things happen in menopause, and I hate and love at the same time using cartoons, but this slide, generously loaned to me by Dr. Fitch, demonstrates that in the early perimenopause, there are changes in both estrogen and FSH that lead to changes in vascular disease and vascular function. In the late perimenopause, the increase in FSH changes the metabolic effects on fat mass and decreases lean mass, leading to changes in energy intake and energy expenditure. We'll talk about these very briefly in just a minute, as well as changes in sleep, insulin resistance, etc. All of these get progressively worse as estrogen decreases further in the postmenopausal phase, and I'll show you some of that information as well. This data, largely from the SWAN study, is well documented in the literature. So I mentioned to you an evolutionary perspective. Let's think about menopause, if you will, as a maladaptive circumstance, never planned for by Mother Nature, if you will, because only small numbers of women historically lived until menopause, and Mother Nature never had a chance to build evolutionary adaptation into menopause because reproduction is over after the last menstrual period. Our theory, published by Polykov, Naftalin, and myself back in 2011, is that the menopausal physiology for a number of endpoints, including our subject for today, weight gain at menopause, has to do with an adaptive benefit of low estrogen during breastfeeding. So just for example, in breastfeeding, there is an increase in lipoprotein lipase, a subject we'll talk about in just a second, which increases the fat in the bloodstream that goes into the breast milk, increasing the fat content of breast milk, evolutionary advantage or positive adaptation during breastfeeding, but that increase in lipoprotein lipase also changes the cardiovascular risk in menopause, which would be considered maladaptive. Hot flashes may be a way to improve radiant warming in a baby at the breast during breastfeeding, but certainly hot flashes and night sweats, which I'll address in just a minute, as well as other sleep disorders, are maladaptive, and particularly maladaptive in terms of energy metabolism and our food choices. These are also made clear by the following 2 points. Might weight gain at and around menopause be controlled by those same mechanisms that increase diet and appetite during breastfeeding? Let's think about that. An additional 300 to 400 calories a day are required for breastfeeding. And given the fact that many of the genes controlling lactation are documented to turn on during the low estrogen of menopause, might our women's bodies at menopause simply be programmed to increase their caloric intake as a result of this genetic phenomenon of low estrogen? Again, feeding into my evolutionary context. This slide, very complicated, you will not be tested on it, demonstrates just how deep our understanding of appetite is at the present time. And Dr. Fitch will talk about some of the approaches to modifying these endpoints that control appetite and caloric intake in her discussion of treatment. But I wanted to mention that we really have a profound and growing understanding of this subject, but it's complicated, a subject that I will touch on only very briefly. So at menopause, when estrogen falls, there is an increase in food-seeking behavior and a decrease as it relates to energy expenditure and increase in caloric deposition and storage. This is demonstrated in both brown and white adipocytes. I'll mention only the white adipocytes at this moment, but as you can see from this slide, when estradiol binds to its receptor, there's an increase in lipolysis. And in menopause, obviously you have a decrease in estrogen and a decrease thereby in lipolysis, leading to an increase in storage of calories in white fat. A few expanded comments about weight gain at menopause. Estrogen deficiency is associated with reduced energy expenditure, increased feeding behavior, and documented to increase meal size. When not restricted, we eat more, women eat more following menopause and in an estrogen deficiency state. Both age and menopause synergize and are associated with changes in adipose tissue metabolism, as I just mentioned, leading to an accumulation of fat, and in particular, a truncal distribution of fat and unhealthy metabolic fat. Deleterious changes in inflammatory markers and adipokines correlate strongly with increased visceral adiposity at menopause, and lower sex hormone binding globulin levels in menopausal women increase insulin resistance and type 2 diabetes risk. In addition, we have many social, environmental, behavioral factors, which include lower levels of physical activity related to both parity, as I've shown you, family history, marriage, and earlier experience, that is to say, childhood overweight and obesity are strong factors for obesity in later life following menopause. Let's talk also, or at least mention, that estrogen deficiency in the menopausal transition and early menopause can lead to frank depression in susceptible individuals, depressed mood in those that are less susceptible, and ultimately contribute to weight gain across the menopausal transition. And one of my favorite issues is that vasomotor symptoms, particularly those occurring at night and leading to poor sleep quality, change women's, and by the way, men with hot flashes, food choices, and shift them more towards simple carbohydrates, which increase insulin and cause weight gain. So a couple principles of energy metabolism. Many individuals would love to blame high fructose corn syrup for the increase in overweight and obesity in our society. And that was clearly the case, but is not the whole story. Because as you can see by these two shaded areas, high fructose corn syrup in the darker shading, cane and beet sugar in the lighter shading, and here the increase in diabetes per 100 individuals, the changes early on could clearly have been related to these two sources of simple calories, but not so now. So there must be other issues, and perhaps Dr. Fitch will talk about them, that are in play, at least in modern times. Weight loss and weight gain are in constant push-pull, and these are the factors in brief that lead to decreased calories, increased activity, the benchmark of how we help women lose weight, and obviously those other issues that I've already mentioned, pulling in the other direction and aggravated at menopause. Dr. Fitch will talk to you about some of the newly discovered, newly in a relative sense, gastrointestinal peptides and how they control appetite, because they're an important focus of the interruption of those appetite signals that are primary to some of our newer therapies for weight loss. So let's get very quickly to office evaluation and goal setting. You don't have to lose a lot of weight to have benefit in terms of health. Only 5% loss of body weight can improve hemoglobin A1C, blood pressure, total cholesterol, and HDL cholesterol. And if one were to be successful in losing 5 to 10% body weight, you can add in a reduction in triglycerides an independent risk factor for cardiovascular disease in women with only 10% weight loss. The office environment that we portray to patients with overweight and obesity is very important. One must have places where these individuals can feel comfortable. They will need chairs and places to sit without arms because many of them will not be able to fit comfortably in standard chairs with arms. We need exam tables with step-ups, large blood pressure cuffs and large gowns, et cetera, for our patients who need to be made comfortable. We need to have an empathetic, respectful, and supportive staff to care for them when we are not actively and personally involved. The initial visit is not much different than initial visit for a new medical problem. Includes a history, physical exam, laboratory tests, etc., and a focus on what are the behavioral and goals for that individual, behavioral problems and their goals and expectations. We are part of the problem when we practice medicine. There are a huge number of medications we prescribe, often important medications, but often without consideration of their impact on appetite and weight, and these can be modified frequently very easily. Set realistic goals. Couldn't say this better than just set realistic goals. I already mentioned that modest amounts of weight loss, 5 to 10%, have considerable medical benefits. And we need to talk about behavior because behavior is critical to how we move and exercise, how we eat, and what we eat. There are many roadblocks that we will come up with in the process of taking care of these patients. We need to have the patients take stock of their own roadblocks and how they can modify their behavior, identify their own roadblocks, and address them without shaming and without criticism. We need to acknowledge how difficult behavioral change and weight loss is and develop plans and short interval follow-ups with patients in order to avoid and overcome their roadblocks. The basic principle of calories in versus calories out is absolutely true. It's physics, but it's a moving target as individuals gain and, more importantly, lose weight. And ultimately, it might send the wrong message to patients. Namely, they cannot control physics and they may not be able to control their diet or exercise. That's not a message we wish to send. A good point of view and record is a 500 calorie deficit, if a patient can stick to that, should lead to about a 1 pound per week weight loss, which is a healthy amount of weight loss, which hopefully would be sustainable for a given patient. Obviously, exercise is critical. It's extremely difficult to have a persistent 500 calorie per day deficit from diet alone. I would say it's impossible. How do you start? Where do we figure out how much a particular individual's diet should include in terms of calories? There are multiple calculators. Here's just one, free on the internet. And if you don't have it, when in doubt, start with 1,500 to 2,000 calories a day and have them keep very good records of everything they eat, because there are many hidden calories in what we eat. There are calorie apps and tracking apps free and available on the internet, and I recommend you consider them. And also, for the International Menopause Society, the impact of estrogen deficiency and/or hormone replacement therapy after menopause may be critical to improving those endpoints, biological, psychological, and social, that I've just touched upon in this talk. I'd like to then now welcome Dr. Angela Fitch to pick up where I left off and talk about treatment of overweight and obesity in our society. Thank you very much.
Thank you, Dr. Simon. And while Dr. Fitch is pulling up her slides and sharing her screen, let me remind the participants, if you have questions, use the Q&A button. The chat button is disabled. So if you have questions, use the Q&A button, and we will take questions after Dr. Fitch's lecture. Thank you.
Thank you so much, both Dr. Simon and Dr. Goldstein. I think, Dr. Simon, we're going to adopt you into the Obesity Medicine Association for that wonderful presentation and understanding of the disease of obesity. And now we're going to focus on a little more around the effective obesity treatment strategies. I do serve as on the advisory boards of several companies that do work in this space as the president-elect of Obesity Medicine Association. There's a lot of people that want to talk to me about the disease of obesity, but that will not affect anything in my talk today, as I do talk to a lot of different people. Our objectives today are going to be to understand the most effective treatment to the disease of obesity using the pillars of obesity treatment, which I'll explain in a second. Review pharmacotherapy for obesity and how to develop an obesity treatment plan, and gain knowledge of how to personalize the treatment plan for optimal outcomes with shared decision-making tools. I feel like shared decision-making in many areas of healthcare has been employed for years, for centuries, so to speak. And we need to really engage patients now in shared decision-making as our treatments are becoming much more effective. So patients need to understand what treatments they have and be able to apply those treatments to their desired goals. So as Dr. Simon mentioned, obesity is a chronic treatable disease, and it's important to recognize how complicated obesity is, because it's not just about calories in and calories out. As he stated, there are many drivers, genetic drivers, menopause, life transitions, many drivers that drive the individual human body to have a dysfunctional weight regulation system. And so obesity, the WHO definition, is a disease in which excess body fat has accumulated to a level that may have an adverse effect on health. And it's important to note that the definition includes excess body fat. Nowhere does it include weight. Yet we use weight as the screening tool, if you will, to identify obesity. But we want to recognize that it's more than just BMI. It's about biology, not just BMI. Body mass index is a screening tool to look for the disease of obesity. And so once you've identified that that BMI may be abnormal, looking at other characteristics that are leading to that excess adiposity having an adverse effect on health is what we're really trying to treat and change. But for now, BMI is the way we classify obesity, because there is data to show, even though the data comes from mainly Caucasian people and the amount of data is quite low. So we must take that into account for other races in particular, especially in Asia and other areas of the world. Your BMI can actually be lower and you can still have the disease of obesity. So again, recognizing that BMI is not the end all be all, but at the moment it's what we use to try to identify the disease and the severity of disease by using these classifications, not just the term morbid obesity or other terms, like we said, that we're stigmatizing. Obesity treatment has been portrayed in this pyramid fashion for a long time. But the important thing to note here is that we must increase our treatment intensity. The intensity of treatment increases as this pyramid expands, essentially. And the reason for increasing our treatment intensity on the left here is our increasing health risks and increasing adiposity. So a patient with an increased adiposity measured by potentially an increase in BMI and increasing health risks is going to need the most effective treatment to get them to their goals, which are listed on the right-hand side. And the reality is that while, as Dr. Simon mentioned, lifestyle modification is critical to all of our lifestyles for various reasons, meaning it's good for us to improve our lifestyle every day just for our basic human functioning and health and well-being. But it does not produce a lot of weight loss, unfortunately. our lifestyle therapies alone only produce about a 2 to 5% weight loss, which is quite a struggle when people repeatedly do that over and over, trying to achieve a 20 to 40% weight loss goal, which is very challenging to achieve other than with surgery. Now, I will say, if you notice that from a pharmacotherapy standpoint, our pharmacotherapy is getting much better at now producing anywhere from a 15 to even 25% weight loss with some of our newer medications that are coming onto the market. And so as we're getting better treatments, we're going to have to employ these treatments in a little more specific way to each patient. The reality is this pyramid doesn't necessarily sit in a pyramidal fashion either, because the reality should be that this should cross over back and forth, because surgery is not the end all be all of treatment, because this is a chronic disease. And so we must look at it as patients moving through these cycles and focusing on these different intervention strategies. These are all different intervention strategies that if we employ them, we can get different results, and we can get them throughout the life course of the patient. So even a patient after surgery may likely need pharmacotherapy down the road, or may employ, for example, a prescriptive nutritional interventions, which is using meal replacements as a way to prevent weight regain and or lose weight that they may have had recurrence in. As Dr. Simon showed, the real challenge here is as we make a change on the left-hand side, as we decrease our calories to increase our activity, unfortunately, our biology responds opposite to that, causing us to regain this weight. So that is the dysfunctional process that is actually functional in the beginning as we talk about evolution, because if this process was not designed this way, we would have all evolved off the face of the earth during times of starvation. So this is a protective effect of the human body. And I tell patients all the time that unfortunately, losing weight is not natural. In other words, you're going against Mother Nature if you're trying to lose weight. It's not a normal physiologic process. Human body is not engineered for weight loss. So in order to make it happen and sustain it, we need help on treatment. We use a 5A's treatment model. This comes from the Canadian Obesity Network, but we use it across, I think, the world, right? Which is to first, as Dr. Simon mentioned, ask patients if it's okay to talk about their weight. Because again, people with obesity have experienced multiple levels of trauma throughout their care. And that trauma leads to that internalized even stigma and bias that somehow I am doing something wrong because I cannot control my weight, even though we know that biology controls our weight and we're trying to control biology, which understanding that and coming at it with an empathetic approach is critical. Then we assess for comorbidities, we assess for other reasons for the weight challenges. We advise people on the treatment plans that we have. That's the shared decision-making part there in gray. We agree on a treatment plan, and then we insist on it happening. This is a nice article from my colleague, Dr. Scott Kahn, about some practical suggestions, and this is for any clinical practice, not just for primary care, but could be employed anywhere in this ABCD approach. And I'd like to highlight this escalate treatment when appropriate, the letter E, because I think too often patients continue to feel as if it's just their fault that they cannot control their lifestyle. And so when they internalize that, we tend not to escalate treatment. We say, oh, well, keep trying. And then patients try over and over again to follow that 500 calorie deficit plan. And when it's not working, we need to employ the next level of escalated treatment as we would do with any disease state. And as Dr. Simon mentioned, there are multiple regulatory pathways that regulate adiposity. And essentially what we're finding now in research is that this level of adiposity regulation is what has become dysfunctional. And therefore, again, not the patient's fault of eating too much and exercising too little. That's what people think, or that's what people feel. But the real problem is related to these neurological and neuroincretin hormones that control appetite and drive us to eat and drive us to go the other direction. If we blow up the hypothalamus here and look at the hypothalamus, which is where our biological eating activity is regulated, we have these two different neurons, the AGRP-NPY neurons and the POMC-CART neurons, and they each work together with the AGRP-NPY neurons. When they're activated, they increase food intake. when the POMC cart neurons are activated, they decrease food intake. So it is this sort of yin and yang between these two neurons that we're trying to regulate as we utilize a medication or pharmacotherapy for the treatment of obesity. And that's sort of a high level, what works for obesity treatment. I like this acronym I created called SAME, just to remember, which is we need some sort of structure, right? We need some sort of program or some sort of ability to follow a routine, as Dr. Simon mentioned, in our lifestyle, because the moral of the story, our environment is currently obesogenic, as Dr. Simon spoke of. And so we have to control the environment. If we just live into the environment normally without any thought around how we're going to live into it, it is likely to produce obesity given our current obesity rates. We need accountability. We need a metabolic alteration to promote fat loss. And I think this category is probably our greatest category where we can, as physicians or clinicians, where we can employ treatment options to help patients. Surgery, medications, different dietary patterns, such as potentially intermittent fasting, for example, exercise intensity, the level of exercise that we have, like high intensity interval training that may show to be more effective at fat loss. And then sleep, as Dr. Simon mentioned, is very important as far as affecting our body's desire to store energy as fat. And we're going to review briefly some nutritional interventions, because I think it's important to point out that while we talk about that 500 or even 750 is probably actually the real number as some of the science is looking at it, but we look at that deficit to produce a 1 pound a week weight loss. But really what's also important is not only the quantity of our calories here at the bottom, which we focused on for quite some time, but the quality of our calories and the timing of our nutrition. So again, there's much more research coming into this quality and timing piece. Dr. Kevin Hall here at the NIH in the United States has a great research on the quality piece, the idea that eating more processed foods may have some other reason for weight gain beyond just the calorie level themselves. Meal replacements are a significant way to increase your results in obesity treatment. It is also a very easy way to employ this in clinic. This is from the Look Ahead study, which was a large study across the entire country that looked at obesity treatment, or part of it was obesity treatment in patients with diabetes. And it compared intensive lifestyle intervention to traditional diabetes support and education, which is just individual appointments or a few contacts with the patient. And so using this meal replacement plan here, which you can see is using a Glucerna shake, which is a shake available in the United States, a protein shake designed for people with diabetes, using that as your meal plan along with a healthy meal and some guidance around that meal produce much better results. If you look at the percent reduction in initial weight on the right-hand side, categorically at 0, 5, 10, and 15% weight loss, if you look at the amount of people, for example, in the 10% weight loss category, those doing this intensive lifestyle intervention, almost 40% of them were able to lose greater than 10%, while the traditional services only produced 3% of those people able to get to that 10% weight loss category. So it significantly increases your odds of getting into these higher weight loss categories when you use some sort of a meal replacement plan. Here you also see that the Look Ahead study went out to 8 years. And even at 8 years, some of the more traditional patients sort of caught up, if you will, meaning the weight loss was a little quicker in those patients doing the meal replacements. But ultimately, there still was a statistically significant difference in terms of those two treatment strategies. And if you broke this study down, Dr. Wadden did that, in terms of the amount of meal replacements that a participant did in 1 year's time span, if a participant had 608 meal replacements, for example, in a 1 year time span, which is about 2 meal replacements a day, so to speak, they were able to lose 11% weight loss, while those doing a lower amount of meal replacements, only about a 6% weight loss, only about half as much. So you can see the beneficial effects of these types of what we might call a prescriptive nutritional intervention. Here's a sample meal plan that we give our patients in our clinic using a shake and a meal plan type of exchange program. And giving patients this to go by in the beginning can be very helpful in sort of getting things started and getting things moving in the right direction. Now let's switch and talk about our medications. Again, most of our medications we're going to talk about are available in the United States, but some of the medications are becoming more available, especially in the treatment of diabetes, and becoming more available worldwide as well. When we're treating obesity, it's important to note that we're treating the adiposopathy or sick fat disease, which is the idea that our adipose tissue is inflammatory and adding to other things like metabolic syndrome and other inflammatory type of metabolic diseases. But there's also fat mass disease. So just because a person with obesity doesn't have diabetes or any kind of dysregulation in their metabolic pathways or metabolic syndrome, doesn't mean their disease isn't sort of worth being treated, because there's a lot of fat mass disease that also happens, which would be excess weight on our joints and sleep apnea and other types of things that are more mass related instead of metabolically related. Our medications also facilitate the management of our eating behavior. They can slow the progression of weight gain or weight regain as it relates to patients with surgery, and they can improve health, quality of life, and body weight in people with obesity. And as we talked about those neurons, that yin and yang of those AGRP and NPY and POMC-CART neurons, right? The idea is on this left-hand side, when we activate these AGRP neurons, it increases food intake. So we want to inhibit these neurons. And when we activate the POMC-CART neurons, it decreases food intake. We want to activate those. So you see on the left-hand side, our GLP-1 and topiramate are the medications we predominantly use for inhibiting these AGRP neurons. On the right-hand side, you see that these are the ways that the POMC-CART neurons are activated, in particular, also with GLP-1, which is also why the GLP-1 agents are so effective, because they're actually hitting both sides of these neurons at the same time, as well as working metabolically internally on other disease processes or other processes in the human body relative to our intestinal tract and our insulin levels. So these are the FDA approved medications in the United States, as well as off-label medications that we use for the treatment of obesity, some of which are becoming available worldwide, such as semaglutide, for example, for obesity. And this slide is a bit busy, but I put it together because I want people to understand the difference between our different treatment options and their efficacy. If you look at greater than 20% weight loss, so the idea of I would like to lose greater than 20%. And why would I like to lose greater than 20%? Well, I may need a heart transplant. We have our patients that have that issue. I may need a knee replacement and need to get my BMI under 35. I may wish to put my diabetes into remission. It turns out that putting diabetes into remission requires a greater than 15 to 20% weight loss. If that's my goal as a patient, then I need to get to 20% weight loss. My chances of doing that with a behavior program, such as, for example, this is data from intensive behavioral therapy studies, as well as something like Weight Watchers in the United States here, about 10% of people are able to get into that 20% weight loss category. Yet almost all of the patients that come to see me every day say to me, they want to lose that 20%, and they're going to do that with diet and exercise. And when I tell them, well, great, let's give that a try, there's a 10% chance you're going to be able to do that. That's what the studies show. Some of those patients think to them, they stop and say, oh, I thought everybody lost 50 pounds when they weighed 250 and did one of these programs, because that's what the cover of People magazine says. But that's not the reality of what actually happens. And so because of that, we have to level set people's expectations so they don't feel like they're failing over and over again. And a lot of my patients might say, I had one patient say, I'm going to be one of the 10%. And I said, well, good, let's give it a try and let's see if you are. If you are one of the 10%, that's all you care about, because you're one of the 10%. But if you're not one of the 10%, let's not feel bad about it. Let's employ one of these other treatment strategies we have here that give you a much greater percentage of getting into that treatment category. So you see here with our newer medication, semaglutide 2.4 milligrams, known as Wegovy in the United States, 36% of people are able to get into that 20% category. With our even newer medication, just came on the market in the United States a couple of weeks ago, tirzepatide, which is a GLP-1 GIP agonist now, a dual agonist treating multiple levels of the obesity incretin spectrum. You can see that 63% of people are now into this greater than 20% category, which is very close to surgery. It's important to note that this surgery data is after 10 years of surgery. So in other words, surgery is quite robust in its duration of efficacy, whereas most of our studies here listed are listed for 1 year's duration. I'll also highlight here, even in the 5 to 10% category, you get a substantial increase. So in patients doing a intensive behavioral therapy program, 48% of them are going to lose 5%. That's less than 50% of people. That's less than flipping a coin, so to speak. But when you add even our older medications like phentermine topiramate or liraglutide 3 milligrams, you're now getting upwards of 60% of people into that 5% category. And if you combine medications with intensive behavioral therapy, you can get close to 75% of people here into that 5% category. So a much greater way of getting into more weight loss when people have that goal. And that's that shared decision-making component. Over here in the United States, we have a new player on the market, which is a device, medical device called Gelesis 100. And you can see here too, it has a bit greater efficacy than dietary strategies alone. So for our patients that are wanting something that's not absorbed into their system, that is more of something they take and helps them to control their eating in a different way, which we'll talk about in a second. This is Gelesis 100. These are capsules that the patient swallows. I'm understanding there's some work going on in Europe too with a different product as well, but capsules that you swallow that are made of a hydrogel. So they are a hydrogel that when you take them with water, they expand in your stomach and then take up space, also likely adding to not only satiety, but also making changes to patients' gut hormones as well, potentially. And here you can see the data that I just presented showing the 5, 10, and % weight loss versus placebo that was statistically significantly different. In the interest of time, I'll move through some of these slides quickly, but I wanted them for your reference, which is, questions you may ask yourself as you're using an anti-obesity medication. Does the weight loss goal suggest the need for medication in that shared decision-making process, right? Am I trying to get 20% weight loss? Am I trying to get 10% weight loss? What does the patient want to do with that? What are they willing to do in order to obtain that? When to add medications, and what are you treating? Are you treating obesity, behavior, appetite regulation, energy expenditure, or the metabolic disease or the sick fat disease of adiposopathy? We're also now using many more medications to use in addition to a surgery. So in the sort of older days, we thought of surgery as our treatment. Now we're looking at surgery and medication together, not only to prevent weight regain long-term, but to also improve outcomes, especially with people who have higher BMIs. So when you see a patient with a BMI above 50 in particular, those patients did better when we combined surgery with the medication right off the bat after surgery. It was 3 months after surgery, the medication was started. And those patients got down to a BMI of 33.8 versus a BMI of 42. So again, we're getting greater than that 20% weight loss when we add those combination therapies. So don't be surprised if you see, a patient, doing both. How do we choose medications in the United States? We do it based on coverage, unfortunately, because for a lot of times it is not covered by insurance. Medicare does not cover anti-obesity medications in our United States. Medicaid, which is our programs that are state dependent, are also dependent on the state. But also when we're just looking at medication, assessing for contraindications or risks, assessing for double benefits, does this patient also have migraines where topiramate would be helpful, or depression where bupropion might be helpful? And then does the patient have diabetes, prediabetes, or insulin resistance? Because that's going to be where you're also going to see where you might have overlap with one of these medications, such as metformin, SGLT2s, or GLP-1s, or the new GLP-1 GIP dual agonist tirzepatide. And here's the data on semaglutide 2.4 milligrams from the New England Journal last year, showing this very significant weight loss in greater than 20% weight loss in over 32% of the participants. And here is what we have in the United States, although I must say currently Wegovy is in a significant shortage situation. However, the same medication is also known, semaglutide is also delivered as Ozempic for diabetes indications. And so we do have a lot of cross usage. And certainly if you have Ozempic available in your country for the treatment of diabetes, we do use it off label for weight, even in those patients who do not, because the medications are exactly the same. And here's the data just recently released a month ago on tirzepatide, which is our new GLP-1 GIP agonist. And you can see here where even they're now quoting 25% weight loss. So 25% weight loss, almost 40% of people getting greater than 25% weight loss with this drug. It is currently approved for diabetes only, but it will be approved soon for obesity, hopefully, at least in the United States. But again, we will try to use it off label as long as people have coverage. It's important to note that in our adolescent and pediatric patients, we do have approved treatments in the United States, which is liraglutide 3 milligrams, which is approved to age 12. And we have a new medication, setmelanotide there at the bottom, which is for POMC deficiency and just recently approved for Bardet syndrome, which is another genetic syndrome where obesity is a significant factor. And so for those two syndromes in particular, we have this medication approved down to the age of 6. Dr. Simon already mentioned minimizing weight promoting medications. And again, just a real quick comment on the idea that we want to assess for these treatment goals because we want to help patients get the goal that they're trying to achieve. The other thing to talk about real quickly is that these medications need to be delivered chronically. So again, in this step 4 trial of semaglutide, you see here where they switch to placebo and weight gain recurred. So again, as we switch to placebo, the weight that we lose comes back on. So it's important to think about these medications long-term. And here's how, in summary, we would create an obesity treatment care plan, diagnose the obesity, prescribe a nutritional plan, determine an activity goal, prescribe medication if the BMI is greater than 27 with a comorbidity or greater than 30 alone, because it's more effective than using lifestyle by itself. Evaluate surgery anatomy if the patient's had a history of surgery to make sure there's nothing abnormal in their anatomy. Arrange follow-up frequently, initially once a month, can expand that out to 3 months for that accountability, and consider remote monitoring or chronic care management for more accountability. Thank you so much. Here are some resources that we will leave you with in case you have more questions over the future. And this is a lovely video. If you're not convinced that obesity is truly a disease, it's called Why to SIBO and Obesity, What's the Difference? Very nice short video on YouTube that you can watch that is very, very moving in terms of the bias and stigma that people with obesity face every day. Thank you so much. And don't forget that World Obesity Day is March 4th. So next year on March 4th, we'll look to fight obesity together. Thanks.
Thank you very much, Professor Fitch. That was outstanding. Once again, if you have questions, put them in the Q&A, and there are a number already, so I'll jump right in. Excuse me. The first question has to do with, it says, both calories and exercise are important for weight loss, but which is more contributing to weight loss after age 40?
Yeah, I think most of our data shows that exercise does not produce a lot of weight loss. In other words, you have to do a fairly significant amount of exercise, meaning, you have to be sort of a marathon runner or an Olympic athlete level of training in order to burn a significant amount of calories where you would see a significant amount of weight loss. However, moving is just good for us in general, right? So there are other benefits. We might sleep better. There's studies to show, Dr. Simon, that we have decreased hot flashes, for example, in menopause with activity. So the real reason for being physically active is for these other health benefits, cardiovascular benefits, et cetera, not so much for calorie burning. And that's what we have to, get across to people. They're not going to sort of outrun their fork, so to speak, meaning our dietary changes are the changes we really want to focus on the most. And we definitely want to focus on moving, but we want to definitely, for other reasons.
So interesting. I talk to all my patients, though, as they get into midlife and beyond about walking. For every mile you cover, it's 100 calories, whether you crawl, walk, or run. And, especially as the weather gets nice here and where we live, if you're trying to achieve that 500 calorie deficit, walking a couple, 3 miles a day is a nice way to mix that with nutrition, I think. There's a question here about, and you kind of alluded to it, but I don't think exactly. What do you think about intermittent fasting in these women?
So let me just make a brief comment and then I'll let Dr. Fitch comment. So intermittent fasting has gotten a lot of popularity. It clearly works, as Angela mentioned, but long-term adherence to intermittent fasting has been very difficult for patients to have. And as we've been discussing, this is a chronic problem. It's not something that just goes away. And so adherence to intermittent fasting, I think there's a study I just read in the last year, shows that at a year, it was down to about 20% of individuals who started were continuing to be able to use intermittent fasting as part of their behavioral modification. Comments, Angela?
Yeah, what's come out of human studies, at least so far in the weight management spectrum, is that it is a mechanism of controlling your calorie intake. So it's a mechanism of creating that 500 calorie deficit, right? Because I find for some of my patients, I say, if it's good for them, the moral of the story is whatever works for you is what's going to work for you. And so we can't sort of force things on people because it won't be sustained, right? But for some people, that's what works for them because they say to themselves, I'm not going to eat after 8 o'clock at night, and I'm not going to eat again till 8 o'clock in the morning or 10 o'clock in the morning. And that structure is what provides a structure that's different than the obesogenic lifestyle, right? So you're actually structuring your dietary intake. There's some data in rats and other types of animals that suggest that there's an insulin response, to intermittent fasting that may be of health benefit. And so there is a biological basis that it may have some metabolic advantage, essentially, but we don't know that. We haven't seen that pan out, so to speak, in humans, but that doesn't mean it's not going to be the case. It's just very hard to study in humans.
There's a question here about what's the role of high FSH levels in postmenopausal metabolism? I guess the question really is that just a reflection of low estradiol, but can you separate them?
I think it's the wrong focus. I think the real focus should be on the impact of low estradiol as both an insulin sensitizing agent and as a cofactor in nearly all of the endpoints that Dr. Fitch and I have been talking about. I think the elevated FSH is just a reflection of that low estrogen. It is one of the things we don't have in my evolutionary model. So estrogen is extremely low during breastfeeding, but FSH is also very low during breastfeeding, and that's a dopaminergic effect. As I mentioned, as I wanted to comment for Dr. Fitch, what she likes to do is get a twofer or a threefer for some of her treatments. And being the sexual medicine guru, and many women with overweight and obesity have secondary sexual dysfunction because our society is so focused on lean bodies in terms of our concept of sexual perfection, that bupropion, she can add a threefer for that because bupropion not only causes weight loss and can be used for a variety of other endpoints, but also increases sexual desire.
Question here, Professor Fitch, you mentioned the possible influence of processed foods on worsening obesity, and then you talk about meal replacements. Isn't this counterintuitive?
Yeah, people ask that all the time. It's really processed food that, was researched, like that we think of as sort of more unhealthy processed food, right? So especially in the form of simple carbohydrates. So our meal replacements, while they are processed, are not leading to that, right? We do have, I didn't talk a lot about nutrition because that could be its whole lecture, like in and of itself, but so I touched on it, but in terms of the effective, our meal replacement literature on multiple levels, there's multiple studies, the OptiWin study, the DIRECT trial, which came out of England recently on the diabetes remission of a VLCD using meal replacements. Our obesity treatment space shows great benefit from this sort of prescriptive nutritional intervention is what I coined in that sort of purple box on the pyramid, right? Which is a prescriptive way of delivering something. And like Dr. Simon mentioned, you have to stick with something long term. So you have to like that sort of thing. You should never have a meal replacement if you don't like it. But it's a quick, easy way to get protein. And there's some definite benefits to protein that we didn't talk about much. And again, that would be its own lecture. But we tend to be, we're eating things like cereal for breakfast and crackers for lunch. And, our protein needs aren't getting met like they should be, especially as it relates to weight loss. And so, yes, I understand it's processed, but that wasn't the study looked at processed things like chicken nuggets versus baked chicken, but the point of that study, the ultra processed food study, showed that people actually ate more calories of that food sort of unintentionally. Even though they did not say that the food tasted better, so people might think, oh, you eat more because it tastes better, but that wasn't the case in the study. People just ate more somehow, like because of the quality of the food, whether it was less filling or what the reason, but that was one of the issues.
Dr. Fitch, you sort of mentioned about BMI is just a surrogate. It's really not the same as adiposity, but this questioner is asking about waist to hip ratio. Isn't that more important than BMI?
It is, exactly. I didn't mention that. I should have mentioned that in the beginning. Measuring waist circumference is certainly an easy tool to use to identify, especially the metabolic diseases of obesity that tend to be more deleterious than sort of weight carried in other places. But that also doesn't mean that you might not want to lose that weight that's carried more in your hips, for example. It just means it's not quite as cardiovascularly damaging, right? But it still might mean you can't sit in an airplane seat comfortably. You may have other factors, other reasons why you still want to lose that weight. So it doesn't necessarily make it less important, but it's definitely, an added risk if you look at the waist circumference in terms of the level of risk to the person's health, from a health standpoint.
Pro-inflammatory also.
Yeah, inflammatory states, exactly, and visceral adiposity. In the United States and at a lot of our weight centers, we do body composition testing, which is also, being done by people at home these days. There are home scales that can measure your body composition and tell you your percentage of fat, which is really a study just published 2 days ago in the International Journal of Obesity, actually looked at the correlation between body fat percentage, which has not been done, and mortality, because there was always this, BMI goes along with mortality, and BMI is sort of a surrogate for adiposity. And there was always this dilemma, well, we don't have data to show that it's actually the adiposity, even though it made sense to us that it's the fat, and not like if you've got a lot of muscle, that's not the problem, so to speak.
This questioner.
1 second, sure. Steve. I just wanted to mention, since we have an international audience, maybe Dr. Fitch would like to talk about an alternative BMI system that might be more applicable to our Asian patients.
Yeah, so that's being worked on, as we speak, because it is, at a lower BMI where our Asian population experiences diseases, metabolic diseases like diabetes, et cetera. And that's where it is important, to measure waist circumference, but also, like I said, we're very fortunate. We just measure adiposity and we can tell that, right? I'll have an Asian patient with a BMI of 25 even, or 24, but they have a 45% body fat, which is abnormal. And so that's what we're really sort of, it's the adiposity that's driving the obesity disease process.
There's a question here about, can you speak to using fecal microbiome transplantation?
Yeah, so that's been looked at actually and found to not be effective, even though the science in mice shows it is, right? When they transplant, there is a microbiome associated with leanness, and there's a microbiome that's associated with adiposity or excess adiposity or obesity. And when you take the lean mouse feces and you give it to the mouse with obesity, the obesity goes away. But it has not been panned out, at least in humans. It has been studied very, minimally, meaning the studies have been smaller because it's hard to get people to volunteer sometimes for those types of things. But we do know that it's a gut microbiome change, and whether that's from, for example, with our Genesis 100 product, it did show some gut microbiome recently shown changes in the gut microbiome, and so likely with our GLP-1 agonists, for example, because they're active in the gut, in the gut cells, right? And so there probably is some changes as well. So we know that there's gut microbiome changes with surgery. So surgery is definitely shown, after surgery, they've done studies to show that the gut microbiome switches due to these incretin and other activations with the surgical procedure itself.
Angela, do you want to comment on what dietary changes affect positively the microbiome independent of weight loss?
Right. And so again, that gets back to these sort of, simple carbohydrates, limiting the simple carbohydrates, because those tend to adversely affect the gut microbiome, and also increasing fiber, right? So there's been some studies, especially in pediatrics, because we didn't have a lot of pediatric treatments. We still don't have a lot of pediatric treatments, sadly, despite the fact that pediatric obesity has been a problem for quite some time. But looking at fiber supplementation, even, especially inulin fiber. So inulin is a prebiotic fiber. So it's not just a regular, not just a bulking fiber, but it actually has prebiotic characteristics. And so inulin fiber use can show some changes in gut microbiome. So we will add that to patients, especially because some of our medications cause constipation. So it's another good reason to.
With that in mind, this question wants to know, do you recommend adding bulk to a meal like wheat bran, which is very much cheaper?
Yeah, you can certainly, or even psyllium fiber. I mean, so, that also works. Very similar to like the idea of Genesis 100, right? It's just whether you take it in capsules or take it in a slurry of mixture, right? So all of those things have definite beneficial effects in creating satiety. And so if satiety is part of your issue, that's where it definitely is effective.
This questioner says, if postmenopausal estrogen deficiency causes weight gain, what is the effect of HT or ET on weight?
Yeah, so we have some good data on that, actually, from an old NIH-sponsored study called the PEPI trial. And in the PEPI trial, postmenopausal estrogen prevention, estrogen progestin interventions, everybody in the trial gained weight as they aged, and that, by the way, is not a surprise. The individuals who gained the most weight were those who were on estrogen in the form of Premarin and daily medroxyprogesterone acetate. Those that gained the least amount of weight were on estrogen, same dose of Premarin alone, and those that were on the cyclic forms of both micronized progesterone with Premarin and medroxyprogesterone acetate cyclically gained an intermediate amount of weight. So estrogen's good, progesterone and progestogens less good. Largely, remember, in my evolutionary context, estrogen is fairly good for insulin sensitizing, whereas progestogens have varying degrees of antagonism to that. And progesterone is the hormone of pregnancy. Mother Nature wanted all women who are pregnant to have plenty of calories and plenty of extra fat for that gestating female baby.
Interesting question here. Have you observed a reduction in vasomotor symptoms in people using semaglutide?
Yeah, actually, I mean, anecdotally, I'm not aware of any published literature, although there might be that I'm not aware of in that space. It'd be interesting, to search. We do see like better sleep, for example. It's hard to know if that's from the medication or from the weight loss, and same with the vasomotor symptoms. It might be hard to differentiate between the weight loss and the drug. But the drug also has other beneficial effects, we know too, as far as they are looking at the drug in the treatment of Alzheimer's, for example. There may be an overlap, and again, whether that's related to glucose regulation and the disease process of Alzheimer's, but they are looking at this drug in other research applications as well.
Can you speak to the use of HCG in weight loss?
Oh, yes, we should not do that. That is, so we have a statement at the Obesity Medicine Association, an official statement on our website, a position statement that says that we do not, discourage the use of HCG. The data that we have suggests it's the meal plan that's prescribed along with the protocol. The research was certainly something that was very interesting from a biological standpoint, as maybe Dr. Simon has more data on that from an evolutionary standpoint, but at least from an exogenous administration, it does not shown to be more effective than just that following that. Usually it's prescribed with a very low carbohydrate, low calorie meal plan at the same time, which is really what's likely being effective.
Yeah, just to support what Dr. Fitch said, there are at least 6 that I'm aware of randomized, placebo-controlled, importantly, blinded clinical trials that show no added effect of HCG to the meal plan, which was, as she mentioned, typically a low carb, low calorie meal plan.
In patients who have undergone gastric sleeve surgery, is the use of semaglutide an option if they regain weight after many years post-op?
Yes, exactly. And all of our medication treatments. And really, I probably should have given at least another slide or so on surgery. I work in a multidisciplinary clinic where we do surgery and medical weight loss. And, again, we're talking about this sort of combination in the future, right? It shouldn't be either or. We're starting our patients on semaglutide, even if their trajectory isn't quite on target, even 3 to 6 months after surgery. So we have data, just like Dr. Simon showed the NIH weight loss body weight regulator data that tracker you can use. There's a surgery treatment tracker from the MBSA QIP, which is our American Quality Initiative for surgery. So if you look up bariatric risk calculator, if you Google bariatric risk calculator, you will find this calculator that shows how much weight you should lose, and it individualizes it based on your risks. If, for example, the patient's weight isn't on that target, like they're not losing weight as we would expect them after surgery for whatever reason, we will combine medication, all of our medications. But GLP-1s in particular, some of the research has shown that people after surgery may do better, have better weight loss effects, and whether that's related to the surgery or just because those drugs tend to be better, as we saw, have more efficacy. That's the question.
Dr. Simon, do progesterone-containing IUDs have a weight gain effect? I'm sorry.
I just wanted to comment on surgery before I take the question. Many of us would love to have a really good bariatric surgery program. And as this is an international audience, I just would like to raise some cautionary flags about the risks of bariatric surgery, which are extraordinary and really require an entire team to both get that patient ready for surgery, metabolically stable. You need fantastic anesthesia to go along with your extremely skilled bariatric surgeons, and you need an intensive care unit frequently to take care of these people, to A, get them off their ventilators, and B, to help them recover. So this is not a quick fix that every general surgeon in the world can do on his or her own. This requires a big team. You asked about IUDs. The progestin releasing IUDs have significant amounts of levonorgestrel released into the systemic circulation immediately after they're placed, but those levels go down dramatically and would have less metabolic impact after about 90 days in the uterus. And the lower the dose of the levonorgestrel in the IUD itself, the smaller the amount both absorbed in that initial phase and ultimately.
What is the role of histamine resistance? Does that mean anything to either one of you?
Histamine plays a role. Like we know that like antihistamines are listed on the weight gaining type of medication, although again, any of those medications, we don't have a lot of data on how much weight, even with Depo-Provera, for example, we don't have data exactly on which individual person is going to see that 50-pound weight gain, for example, that they might see. So I think there's some, it's hard to know, and we don't, talk about it a lot in our obesity circle, so to speak, histamine.
And
Yeah.
it's
And
20.
the other thing, Steve, that I would answer is that when we talk about antihistamines and histamines, we usually focus in one area, but we forget that some of the H2 blockers, which are used in the gastrointestinal tract, may have downstream effects on the whole biome and GI system, and they're often used off-label for treatment of warts and other things at high levels. So just a proviso there.
So it's 21 past the hour. I have one final question. Can semaglutide be used on a patient with a history of endometrial cancer?
Yes, there's no contraindication necessarily for any kind of cancer, although I don't tend to put people on it who are undergoing intensive chemotherapy at the same time, just because it causes nausea as one of its side effects. And if you're nauseous from your chemo, that's not really pleasant to be nauseous from something else too. So, but there, has been a lot of data on the GLP-1s post-marketing. One of our oldest GLP-1s, liraglutide, has been out for 20 years. And before that, exenatide. And so the data has not shown any increased risk of cancer, certainly, in these medications, even though the black box warning is for thyroid cancer in rats. There has never been shown any thyroid cancer in humans. So it's certainly considered to be, safe and used in people with a history of cancer. But
Well, I want to thank you both tremendously for an excellent presentation and a lively discussion as well from the participants who put questions into the Q&A. Once again, I want to thank Bessons for the unrestricted educational grant. And I want to remind everybody who's been watching this thing next to my head, talking about the World Congress of the International Menopause Society, which will be in Lisbon, Portugal, the 26th to 29th of October. An excellent opportunity to hear lots and lots of topics as exciting as this one has been. And I really thank you all for your participation and hope to see you all in person in Lisbon. Bye-bye.